Right.
So how important is the pre-op liquid diet?
Okay, so the pre-liquid diet, I know it being really difficult for every patient, not for everybody who wants to do it. It's almost impossible, one of those difficult things, but it's necessary. Um, so the liver basically shrinks, going from a fat liver to a normal liver, and even if the liver is too big afterwards, it's still handleable. If the patients don't do it, we're gonna at least have double the surgical time sometimes. So we need that thing. I mean, it has, at least my surgical times have been shrunk to half the time that we used to do. You know, that comes with experience, of course, but also having the liver the right size. And of course, the damage to the liver, if the liver is too heavy, it's going to be damaged. The liver recuperates itself fairly quickly, but still, you're going to have damage to that liver afterwards because it will bleed faster, it will bleed easier, it's more fragile. So when you put in the retractor, you can actually crack it, it'll bleed. So there's several things. The bleeding it goes up, and the size of the bleeding, or you want to measure it, it'll go up. So again, it's really important to do that the week, 2.5 week or 2 week diet. I'm sorry. Yeah.
Well, this is a great segue into what happens in the event of an emergency. How are you guys prepared to handle a patient's experience if something goes wrong?
Well, so medical emergencies are, first of all, a medical emergency. So we're physicians. Everybody on staff, the physicians are, trained physicians. First of all, the medical emergency may occur at any time, at any place, anywhere that you work. So, first of all, I was trained in trauma surgery first, so that those medical emergencies are, although they seem to be a little tricky, I mean they're something that comes with the territory, and everybody's able to handle them. Basically, I mean, the anesthesiologist knows what he's doing. Even the GPs know what they're doing. They're able to know the basics about resuscitation and cardiac arrest, and those are the biggest medical emergencies. The biggest medical emergency that happens during surgery is basically bleeding, and most surgeons are able to handle it. If you have a surgeon trained first in trauma, it's usually not going to be a problem with those patients. If you get a secondary medical emergency, that's I don't know if we have to compare with the primary medical emergency is when we are there, either a bleeding or something that goes wrong with the heart. The complications that come afterwards, for example, with the surgery itself, coming from the surgery, call it an infection, call it a leak, those medical emergencies are able to be tackled by us anyway, because we are trained on that. I mean, we are, after all, before you become a bariatric, you are a surgeon, and you are well trained in infectious diseases, abdomens, or acute abdomens. So you're able to train and do that at any given moment. So most of those things are handled by myself or with the team. Yeah.
Good. I know, and this is something I just thought about the gallbladder. A lot of people get the gallbladder removed during surgery as well. Why?
Okay.
Why is that?
That's a really good question. So the gallbladder, when you lose weight, about half of the patients will get either gallbladders or slush. That's a given. Now, the reason that we don't take it out routinely is the gallbladder actually adds infection to a surgery. It would be, because I know in the past a lot of surgeons actually, when they did any bariatric procedure, the first thing they did was take out the gallbladder. But it does add infections, complications right to a surgery that just for being that already has a rate of complications that is higher than normal, even though it's scheduled surgery. So if you add a higher risk of complications, you kind of don't want to do that unless you see that gallbladder is already giving the patient problems. or has to come out, we'll do it at the same surgical time. But if not, we'll wait until second time or second. At first, it was criticized. It was a base of criticism for me, and time gave me the reason. There are several articles out there now that actually, back me up on this. That not everybody. It's not recommended to take out the gallbladder on this. Initially, because of the complication rate, infections, and complications with the surgery itself. So, yeah, I mean, 50% of the patients, there's a good percentage of the patients don't have it already, so that they come in and it has been taken care of. There's about a third of the patients that already don't have the gallbladder anyway. So, and there's a few who tell us that they've already been having problems with it. So if we can take it out, we comply with that. We'll just say, it's higher risk, higher surgical time, higher, because the surgical time goes up, of course. I mean, that's a whole other procedure. So, but that's why we don't take it out routinely. But it does tend to get stones or even sludge will give problems to a patient. But it can be taken out on a second surgical time. We don't want to put the patient through a lot of surgeries, but sometimes the best way to do it is just to wait upon another surgery to take it out.
Okay. Next question, and then I'm gonna try to get close to wrapping up.
Yeah.
What happens if the patient has a leak at the barium swallow?
Okay, well that's so if a patient has a leak, or I even have the suspicion, or we are not sure of it, there's about 3 things that I just said. We just go in. We just go back in immediately, even if we're not sure. Sometimes you go in and you see nothing, and which is fine. It's peace of mind for you and the patient. But most of it, if you catch a leak within the next 24 hours of surgery, within the 24-hour boundaries of the surgery afterwards, you have a much better outcome than if you just let it go. And usually they won't close. If you let them go, they will not close. If you catch them within the next 24 hours, they will usually close. So that's the whole deal. We catch them, we get them, we go in and repair it. It can be several things. Usually the leaks are more common in revision surgeries than in a regular patient or first-time patients with let's say a sleep.
Okay. Overall, what is the recovery process from your procedures, whether it be bypass or the sleeve?
Okay. Immediate or sorry?
Well, like how long do you suggest the recovery time be?
For say going back to work?
Yeah.
Okay. So it's post-op immediately. Okay, so it's about so we keep you 48 hours. Keep your patients 48 hours. We don't need to, but we've noticed that the patient does a lot better. Most surgical centers will keep them for 24, and then just let them go, or less than 24. They will be treated as an outpatient procedure. We keep the patient for 48 hours. Patient does a lot better with that, and we can catch complications actually a lot faster, and we can actually cut complications with those 48 hours. After that, for about 2 to 3 weeks, that's about it. The recovery time. By the week time after surgery, the patient's fine to go back to his normal life. Probably not back to work if the patient was doing hard labor or driving trucks. Or I do recommend 2 to 3 weeks. And to go to full-blown exercise or physical activities, I would recommend 3 to 4 weeks before anyone goes back to that. The incisions and everything is really small. The incisions are highly up in your abdomen, so the possibilities of hernias are very low, but I still recommend you wait at least 3 to 4 weeks before you start any hard regimen of exercise. Well, with weightlifting restriction, we recommend 20 to 25 pounds maximum. Just based upon we don't want to get a post-op hernia. It's a really rare thing that happens to our patients. I think we have 1 or 2 patients that actually happens to them, the post-surgical hernia. But we do recommend that 25 pounds is going a lot for the next 2 to 3 weeks after surgery, so that
Awesome.
so you stay under that, you'll be fine.
Okay, and then this will be my last question.
All right.
What do you love most about your job?
Well, everything. Everything. You have people are happy. You get them back on track. For what's not to love about that?
Why did you choose to be a bariatric surgeon?
Well, first, sometimes you don't choose things. Things choose you. I mean, it started out as I didn't really remember how it got started, but sometimes the job starts to choose you. I mean, and it'll be up on that because I used to do a lot of trauma surgery, and then ended up in bariatrics, and the patients kind of choose you, and they say, well, would you do this? And I say, well, okay, but lo and behold, I'm doing this, and I really love it, so we're good.
Well, we know that you're very passionate about your patients, and I greatly appreciate everything that you do for the weight loss community. A big thing is the financing. A lot of places don't offer that, and I think that's something I'll probably chat with Melanie more about. But we definitely appreciate what you guys are doing.
I know a part of it. I don't know the whole thing. It's probably a good thing.
Well, thank you so much for chatting with me.
Yeah.
I greatly appreciate you taking time away. And thanks for just everything you do for people every day.
You're very welcome. No problem.
Awesome.